Welcome to this evening's Fertility Network UK webinar, Fertility and Health Inequalities for National Fertility Awareness Week 2023. Thank you for joining us tonight. I'm Jenny from Fertility Network UK, and I work as the Ethnic Minorities Community Project Worker. And I'm delighted to be joined by our panelists, Avital Raz, Dr. Veronique Berman, Dr. Venkatesh Subramanian, Okorite, Ephraim, and Ruby Relton. Tonight we'll be discussing how systemic and structural health inequalities compound the negative fertility experiences of people from Black, Asian, and ethnically minoritized communities. Our communities are disproportionately affected by worse experiences and outcomes in fertility treatment. Our experiences are not in isolation, and it's important that our voices are heard. The intersections of racism, patriarchy, and austerity impacts upon our lives, and there is still much work to be done. We are part of the system and part of the solution to ensuring more equitable fertility healthcare. The people from racially marginalized communities embody our experiences of othering, difference, discrimination, power, and oppression in our daily lives. So how our infertility and fertility concerns are met and responded to is not only crucial for navigating healthcare systems, but also for our well-being and fertility outcomes. So in tonight's webinar, we'll share some valuable insights and highlight what more needs to be done. You'll hear from our amazing speakers as they discuss the historical challenges, current issues, and ways to address the obstacles to achieving equity in fertility care. So our first panelist I'm just wanted to check is Avital Raz. And I'd just like to check that Avital is in the room ready to go.
Hi Jenny, I'm just looking to check. I think you're going to need to send me, you're going to need to send me his details so I can add him as a panelist. Right. If you can send me his email address, I'll be able to add him and then can join that way.
Okay, so in that case, if we can just, whilst we're waiting for Avital to join, if we could revise the order, and we're going to kick off, if it's okay, Dr. Venki, are you good to go?
No problem.
Perfect, thank you so much.
So good evening. Thank you very much for this opportunity to speak at this exciting webinar. My name is Dr. Venki from Venkatesh Subramanian. I'm a consultant in obstetrics and gynaecology at King's College Hospital. I'm a consultant in reproductive medicine at King's Fertility, and I'm also an honorary senior lecturer at King's College London. I don't have any conflicts of interest to declare. And I thought for this presentation, I'd just like to showcase my own sort of experience of working within the community that I work with at King's Fertility. So the community I work with, so King's College Hospital, it's in Camberwell in the borough of Lambeth, South London. We serve, sorry, my light's just gone off, apologies. So we serve approximately a population of 700,000 people. And we have perhaps one of the highest of backgrounds of Black or ethnic minority communities, making up 40% of the population. In my own fertility unit, we did last year approximately 3,300 cycles. We did just under 2,000 egg collections and just under 2,000 embryo transfers. So a reasonably sized, pretty busy fertility unit. And I'm quite passionate about sort of ethnicity and, the health inequalities that are associated with it in terms of fertility treatment. And why is it such a really important topic? So these are some of the quite important, sort of papers and literature that are resounding and echoing the same theme. Black and South Asian women have the poorest outcome. Interestingly, even if you adjust for other things such as age or other medical problems, they still have a worse outcome. Ethnicity is a really important determinant of, if you have IVF, what are your chances of having a live birth? And we know that it's significantly less in certain ethnicity groups compared with other, for example, white British women. And we know that, worryingly, Black women are the greatest risk of all failure types of fertility treatment. And women who are Asian, from an Asian community, are at intermediate risk of their treatment not working compared to the other background demographics of the population. And I think that this is something that's really important, that we try and understand why this is and what we can do to try and improve our service at King's Fertility. And a very important report that I'm sure may come up later, but it's such an important report, is the HFEA Ethnic Diversity Report. And in 2021, they released this really important report. So what the HFEA do is they collect a wide range of variables about different characteristics of treatment, so your age, paternal age, and among them they collect ethnicity. And it's a really large database. So we're talking, hundreds of thousands of patients. And then for the year 2018, they reviewed specifically with the theme of looking at ethnic diversity and outcomes. And these are the key sort of findings. Black patients have a lower IVF birth rate. They're more likely to have tubal disease. That means the fallopian tubes being blocked. They're likely to start IVF at a later age. If you need to have donors for your treatment, you need an egg or sperm donor. You're much less likely to find an egg donor or a sperm donor from a Black or Asian donor. And white donors are instead used amongst most ethnic groups. And perhaps I found pretty worrying is one of the findings from this report is adjusting for all confounders. You are actually, if you're from a Black or from an ethnic minority community, less likely to be able to access NHS funding for your IVF treatment cycle, adjusting for other confounders that may cause a barrier to treatment. And so there is clearly no equity that we're seeing in terms of the treatment. And what are the implications we found in our own community that we work with? So we think that there's, in the community, one barrier is there's limited knowledge or education in fertility, and understanding among certain ethnic minorities what treatment is available for them and the ways to access this. They're presenting later. So even if you do see a GP with a fertility issue, the referral time and coming here is delayed within an ethnic minority community. We're seeing worse medical conditions that can affect fertility. We know certain members of our community are more prone to severe pathologies such as uterine fibroids. And this is exacerbated by the fact that they present later, so the pathology or underlying fertility disease may be worse. And all this cumulatively is worsening the health inequalities within our community. So what have we done as a local experience? So I think one thing that I think we try to do is, first of all, having a workforce that's representative of the community that we serve. And I think that's important. On a simple level, for example, within our clinic, we speak over 7 different languages: English, French, Spanish, Portuguese, and many more. And this helps us to be able to relate and manage the needs and understanding the values of our community. We are trying to ensure that the care we make is accessible for our community. So how have we done that? So for example, patient information leaflets, we're trying to make sure that these are readable, understandable, and we are currently translating into languages to serve other demographics of our population. We undergo mandatory training of our staff in equality, diversity, inclusion, key concepts of cultural competency and unconscious bias. What does that mean? We understand that our own cultural beliefs may be different to somebody else's. We may have unconscious biases about certain ethnicities, and actively challenging these can improve our patient care. And we are specifically targeting clinical pathways to address the need of our community. So an example of a clinical pathway that we have done to try and improve a specific disease affecting certain racially marginalized communities is sickle cell disease, which we know is more prevalent. So we have targeted special protocols that specifically treat and manage and address the needs of patients with fertility issues and sickle cell disease. And we are constantly taking ownership and accountability, and that's really important. I think we as fertility providers must really take ownership and accountability of the services we deliver for our community and what are the outcomes. And we're constantly evaluating and auditing in terms of how our care pathways are for the community, how we are able to reach out for them, how we are able to provide education, how we provide treatment, and our outcomes. And importantly, we are constantly reviewing and reflecting on patient feedback from our community, and are we delivering the service and care that they deserve? And in the future, we are planning to improve our accessibility and to try and reduce this burden of health inequality that we see. We are planning to open fertility educational workshops within our local communities. And I think one of the things that we found in our sort of background talks that's really important is engaging with community leaders. For example, an example of this is that we have found that in certain ethnic minority communities, there may be religious perceptions or beliefs that fertility treatment is bad or wrong. And we are keen to work with these key stakeholders, such as pastors or church leaders, to dispel these myths. We want to ensure that our clinical pathways are robust and effective, and similar to our sickle cell, we are in the same process of doing for uterine fibroids, evaluating that our protocols meet the needs of our community and auditing this. And I'm proud to say that King's Fertility, we're very focused on research and innovation. And in this particular field, we will be leading and looking at seeing why we are having barriers in accessing our service, what can be done to improve this. And my presentation is short, but I think I will leave it with a very important quote from Martin Luther King. And I think it's really important and why I'm very passionate about this topic. And that is that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I personally think we at King's Fertility are doing more, but we can do more and we will do more. Thank you.
Hi, Dr. Venki. Thank you very much for that amazing presentation. And it was really great to hear about all the hard work that's being done to address some of the disparities and making the services more culturally sensitive and inclusive for people from ethnic minority communities. So I'd like to welcome our next speaker on the panel, and that is actress, musician, and theatre maker, Avital Raz. Welcome, Avital. Please introduce yourself, and can you say a bit about why this topic is of interest to you?
Hi, thank you. Yeah, as Jenny said, I'm a musician and a theatre maker, and the last show I made is called Unnatural Cycles, a Ghost Story, and it's all about my multiple miscarriages and fertility journey, and about my grandmother and her experiences surviving the Holocaust. When I was working on it, I didn't entirely understand why the two things were connected in my mind. I had some vague feeling that somehow my fertility and my grandmother's story and the fact that her whole family was killed was connected, and that somehow I'm expected to well, I have 10 cousins on my the other side of my family. They had 10 kids, so in some way we were expected to make children to make up for the part of the family that was killed. While I was working on this show, weirdly, I was already performing it after 2 years of work, and as I was performing it, my mother had a dinner with just some random woman who it turned out was gave testimony in the Nuremberg trials about practices that Nazis did to Jewish women, specifically about their fertility. So I learned about that and researched it, and it turned out that afterwards in the US in the 50s, there were a lot of Jewish women who had fertility problems, and there was what was considered a miracle drug at the time called diethylbestrol, or DES. and that was given to many Jewish women in the 50s. Both my grandmothers had fertility issues, and they took it. And as a result, after sometime in the 70s, the drug was discontinued because they found out that it causes severe fertility issues in future generations. As a result, both me and my sister are unable to have children. And we both had genetic mutations that are directly related to this drug. So that was just a very interesting thing to find out as I'm working on this show. In my show, I basically made something up that linked the two things, but then I found out that there's a real connection. So if it's all right, so this show toured about 12 times, and when we were working on it, me and Jenny from Fertility Network here did a workshop, a creative writing workshop for women who have had a miscarriage or difficulty getting pregnant, and that was part of the what fed into working on the show. And I also felt that I want to give a creative outlet. It was very difficult to find participants because I found that people are either very traumatized by their experience, or a few years have gone by and they just don't want to open up that kind of worms again. So we struggled a bit. So this show toured, and now I've been working on a film version of it, and I've just prepared for today the trailer, which I'd like to show you all. But before that, I just want to say two things specifically about this subject. So one is about being an immigrant in this country, and it taking 1.5 years to get my NHS IVF done because of my immigration status. And at the age of 38, that was not very nice. And another thing, which I was reluctant if I should even talk about, but I will. And I'm not trying to generalize here at all, but I did have a myomectomy, sorry, a hysteroscopy at this point, an investigative one, and I got a leaflet saying that 1 in 10 women have severe pain, and I had one before and had very severe pain, so I had asked for the additional pain management, and then I was told that that would take an extra 6 months if I was going to have that. I didn't want to wait, but when I did get from my GP a diazepam. Anyway, when I did come to do this, it wasn't the regular doctor that I have, and it was someone who, again, really not trying to generalize here, my regular doctor is also Middle Eastern Muslim, and he's great. But in this particular situation, I was asked a few times about my name and is it a Jewish name? And then I was denied pain medication. I wrote a complaint to the NHS about this and never received anything back. So that was a very traumatic experience. And again, I have no idea if I'm connecting things that shouldn't be connected, but I did suspect that maybe there was something there. And since then, I've been a bit more wary about telling people where I'm from and what my ethnicity is. And yeah. So anyway, that's what when I was asked to prepare this, I was recalling that experience that I had kind of blocked out. But if it's all right, I'd like to show you my film trailer.
Would be great.
I want to tell you a ghost story. And I also want to tell you a true story. We one day will have a baby. Eating and scratching yourself in front of the TV for hours. I heard about the baby. I'm sorry. But you grieved enough. You need to dust yourself off and get off the sofa. You need to try again. Natural cycles. Natural cycles. Natural cycles.
Hello?
Doom, doom, doom.
Is this Miss Messenger? I'm calling from Western Clark Hospital. We have your results.
Your generation likes to wallow. So does your parents, with their therapists and self-help books. In my day, everyone suffered. Natural cycles.
Hello?
Nobody thought they deserved to be happy. And for the next year, neither of us could bear the thought of trying to conceive. Yet every day I was conscious of my body aging. Oppressive. Like the loud ticking of a clock in an otherwise silent room. I was angry at my stupid body for not managing to do what every idiot can do. Reproduce. Blessed art thou amongst women. Blessed is the fruit of thy womb.
Hey, thank you so much for that, Avital. It was a very powerful film and really looking forward to seeing more of that. Thank you. So we'll now move on to our next speaker. I'm delighted to have Dr. Veronique Berman here from Chana, and she'll be sharing a bit about her work and the culture and religious factors within Jewish communities. Welcome.
Thank you very, very much indeed. Firstly, thank you for the opportunity to join this very important conversation. Avital, that was really very impressive and very moving, and quite a number of the themes that you mentioned when you were giving your pre-presentation, and then in the images that I could see, resonated extremely loudly with me with the work that I do with Chana. So Chana is a charity that was set up almost 30 years ago. Actually, we're celebrating our 30th anniversary this year, to support couples in the Jewish community dealing with all areas of reproductive health. So originally it was set up to deal with couples who were struggling with primary infertility, which you've spoken about already. But we support couples who deal with secondary infertility as well, so the inability to grow their family further, couples who have had miscarriages, or later losses and even sadly stillbirths, couples who deal with intimacy issues, sexual dysfunction, both male and female, couples who have genetic issues, which is something that is very pertinent, not only to the Jewish community, but to lots of minority groups where they are more likely to carry recessive genetic disorders or genetic traits. And we also support individuals in the community who have had a cancer diagnosis and have to have treatment that could impact in the longer term on their fertility. There are I think a very important point that I want to make before talking about specifics within the Jewish community is that we at Chana have a very strong feeling that fertility issues, whichever they may be, and I've listed a fair number just there, really know no boundaries. It doesn't matter where you come from, what your religious or ethnic background is. Any couple that are dealing with a fertility struggle, and whatever that struggle may be, because it comes in lots of different shapes and sizes, it really does know no bounds, and it is a terrible, terrible struggle, and something that is really often quite little understood. I think the thing that we are aware of within a religious setting is that the basic struggle is the same wherever you are. But when you are observing a particular faith or particular culture or part of a particular community, the pressures can be different, and they can be either driven by the social norms within your community. So, for example, the Jewish community is not alone in being a very family-oriented community. There are many others that could be part of this conversation as well. But many of the calendar highlights, if you like, within the Jewish community center around the family, center around family celebrations and gatherings. So, of course, that's going to be extremely difficult and painful for couples that are struggling with something. I think also the fact that for many, where the education that they have received and the conversations that are had are often maybe a little bit more limited, or maybe a little bit more quiet about subjects such as this, can also make the struggle greater, because we don't necessarily talk about intimacy. We have considerations about how we dress and what we wear and the way we behave, and this is often taught at a very, very young age, and therefore later on, when these subject matters become acute, or there is a concern about possibly a fertility issue or an intimacy issue, the conversations are more difficult to have, because there isn't necessarily the vocabulary or the language or the ease with which one could have a conversation, which sometimes in mainstream society, these conversations are more easily had. And so I think when the question was originally set to me about inequalities and infertility and how that might impact on the community, I think that I emphasize that the struggle is the same no matter who you are and where you come from. But I think in a community where the emphasis is so much on family, and where the language and the vocabulary are often not necessarily so easily or readily available, I think that's definitely something that we at Chana work very hard with our couples to help them to overcome. One of the things that we do is we have an expert medical panel, a team of medics across all areas of reproductive health, who will be there to give a multidisciplinary team approach to the couples, so that they can get lots of different opinions, but all in one space. And I think that that's something that I know that Avital, you alluded to, the difficulty to get appointments and the difficulty to reach, whether it was a treatment procedure or a pre-treatment procedure, and having all the necessary steps put in place. I think that that's something that we're just seeing more and more of. And I don't think that that's particular to our community, but I think sometimes the ability to communicate your requirements and be able to have the conversation with the GP, to start that conversation, and to be able to talk about the difficulties that you're having and the timelines and the restrictions that often are imposed because of religious practice and observance when couples can be intimate, and trying to explain that to somebody who's not familiar with those practices can sometimes really be quite limiting. And so I do spend a lot of time talking to practitioners across the board, trying to explain the religious sensitivities and the limitations that sometimes very observant couples have, so that they can make themselves understood more easily. And I think that that's something that couples often do struggle with. Another point that actually, Avital, you alluded to, and that was the not necessarily everybody wants to have a child very young. Sometimes couples want to choose when they want to have their children. Sometimes they haven't found the person with whom they want to have their child. And that's almost taken for granted because of the age limits and the requirements, and your film depicted it so clearly, the ticking clock. But one of the things that we really are trying very hard to open the conversation and encourage the conversation is that women should be thinking about freezing their eggs, that this is something that would give them a little bit more time to find the person they want to have their child with, or to be in the right circumstances to have the child that they so long for, but to give them that extra insurance, if you like, of time to be able to go ahead and do that. I think that that's something that is a conversation that we're trying to encourage more and more people to have. And I think that that's really an across the board conversation, not just specific to the Jewish community. I also mentioned genetic issues, and I think that this is something that is very pertinent to us. We work closely with other organizations that encourage either preconception screening, genetic screening, or young adults as early as high school, year 12 and year 13, when they're starting to think about their life choices, or when they're in university, not at all at the stage when they're planning on starting their families, but that they gain the knowledge and the awareness of their genetic heritage as well as their Jewish heritage, so that they understand that if a situation does arise where there are carriers of recessive disorders, which, as I stated, is not unusual in ethnic minorities, not just in the Jewish community, that they are, if you like, armed with the knowledge, and therefore they can take necessary steps. They can encourage the person that they are planning to have their child with to also get the screening done, so that if they discover that they are both carriers, that's fine. They can then have choices, and there are several choices that they can make, whether it's pre-implantation genetic diagnosis or whether it's prenatal screening. There are different choices available, and what we do is to help the couples to navigate those choices and to go through the steps that they need to ensure that they can do the best that they possibly can to have a healthy child. I think that the help that people need is, I've obviously alluded to education and understanding, but also that the healthcare professionals that they're going to encounter have a really deep understanding of the cultural and religious needs, but also the emotional support. I don't think that one can ever understand or really underestimate the emotional strain on both members of the couple, and it won't necessarily look the same for both members of the couple. They will express themselves differently, they will communicate differently. One may communicate, one may not communicate at all. Whatever it may look like, we are very aware of the fact that emotional support is extremely important, whether couples will come together or separately, whether they want to have their support over the phone, whether they want to have face-to-face support, group support. It looks different for different people because the problems and the challenges that they're dealing with are different, and no two people would even deal with the same situation in the same way. So I think that, you know, we're very, very mindful of how people wish to be supported. I think that there's also many questions that people of faith have around about managing to navigate a situation, whether it's medical or emotional, within the constraints of the rules and regulations that their faith dictates, or the rules that they live by. And that really is, I know, the same for many faiths. And so we have a rabbinic panel, a group of rabbis that are there to answer the questions, to give guidance for those who wish to have that guidance. And so really the support that we offer comes in different forms, depending on what the people need, whether it's a religious guidance, a question to be asked, a conversation to be had, a discussion to be had, so that the couple can reconcile in their minds what it is that they need, whether it's the emotional support, so that would be in the form of talking therapy, emotional support, whether it's in the form of medical information from the medical panel, or a combination of all of the above. And I think that, you know, being able to reach out to healthcare professionals and give them an insight of what the community looks like, how the pressures are maybe the same as every couple, but slightly different because of the family pressures, because of the expectation. It's like Avital alluded to, the expectation that people will have large families because we're replacing a community. It's a conversation that's been had many times, but there's no expectation at Chana how many children people are going to have. It's if they want to have a child, or if they have suffered the loss of a child and need to find their way through that terrible, terrible loss to be able to rebuild their lives. Whatever it is that they're reaching out for, we will try to be there for them. As I stated, we do support members of the Jewish community, but I work very closely with many charities such as Fertility Network UK. It's a really important part of what we do to be able to collaborate with other charities so that we can share ideas, we can share information, that we've gained knowledge, we share it, they've gained knowledge, they've shared it with us, so that whoever comes our way, we're able to signpost them to the right organization that can give them support. We also work very closely with the HFEA, the regulator of the authority, because one of the things that they set out to do is to provide impartial information. And this is a really difficult area for couples. There are many pressures. There's a lot of vulnerability. There's a huge amount of information. I think it's so unusual that you have patients who have a medical need, and at the same time, in many, many cases, over 60% of the cases, they're going to be paying out of their own pockets for their treatment. They're being consumers who are looking for a service, but they have a medical need. It's a very unusual predicament that they find themselves in. And so the clinics are looking to sell a product, but the patients have a clinical need. And that is a very difficult tightrope to walk, where you have couples who are trying to do everything they possibly can to achieve that longed for child. Do they go for the add-ons? Do they pay all that extra money? Do they throw everything they possibly can at it, when sometimes there isn't the science to support it? And so the ability that we have to learn and to gain from the regulators and all of the information that they're putting out in an impartial way is extremely, extremely important. So I really appreciate the opportunity to share a little bit of an insight into the work that we do, and an insight into the community that we support, and happy to continue the conversation further. Thank you so very much.
Thank you so much, Dr. Veronique. It's been so valuable to hear about all the work that you're doing, and as always, to have you collaborate with us on increasing awareness. So thank you for that. And the next speaker is Okorite Ephraim. Welcome, Okorite. Please, can you introduce yourself and tell us about your work?
Good evening, everyone. I have just completed my Master's in Women's Health at UCL, and my project focused on Black women's experiences and attitudes towards fertility treatment in the UK. I'm very passionate about addressing racial and gender bias in medicine, so completing the project was really inspiring for me, and I'm really hoping to continue some further research in the future. But what I'm going to be talking through today is my project, which I titled Unseen and Unheard: Black Women's Experiences and Attitudes of Fertility Treatment in the UK. Can I have the next slide? Thank you. So in 2018, approximately 54,000 patients used fertility treatment across the UK. In the report titled Ethnic Diversity in Fertility Treatment 2018, the Human Fertilization and Embryology Authority, so the HFEA, noted that despite the increasing diversity of patients who are seeking fertility treatment, there is still a lack of research on the attitudes and experiences of ethnic minority patients. So according to the report, only 1.3% of treatment cycles were accounted for by Black women, which raised concerns regarding the accessibility of fertility treatment for this demographic in the UK. So this finding suggests that there may be significant barriers that are preventing Black women from accessing fertility treatment, and this may be related to several factors like cultural factors, social factors, and financial factors. And this does draw parallels with the US, where Black women are also less likely to seek fertility treatment. So the report also highlighted that in the UK, there is evidence that Black patients, particularly those identifying as Black African, have lower IVF birth rates compared to other ethnic groups, and Black patients have the lowest chances of successful treatment. At the moment, research on differences in fertility treatment outcomes frequently concentrates on individual health factors like fibroids, obesity, diet, and smoking, which can negatively affect the treatment results. However, there has been little attention to exploring any structural biases that can hinder and impact access to fertility treatment and healthcare services. So my project aimed to address this gap by exploring Black women's experiences and attitudes of fertility treatment in the UK and centering the voices of Black women and emphasising their stories in the fertility space. Can I have the next slide, please? Thank you. So my aim is to provide valuable insights into the unique challenges faced by Black women when accessing and undergoing fertility treatment, so including their expectations and their perceptions of any services. And I did this using semi-structured interviews to help identify any barriers that Black women face when accessing fertility treatment. Next slide, please. So from the interviews, I got a lot of insights into what Black women were going through when they were facing fertility treatment. So they dealt with issues from financial issues, access to care, decision-making, emotional experiences, and the influence of culture, support systems, self-advocacy, and identity. So these are some of the results, things that Black women did bring up when I was interviewing them. So for example, the cost of the treatment, waiting times, their thoughts on fertility and motherhood, the use of insurance, the availability of Black donors, whether that be egg donors or sperm donors, communication barriers with healthcare professionals, striking the balance between asserting their agency and advocating for themselves, and also their representation in clinics, and also desires for parenthood and religion. Can I have the next slide, please? Thank you. So these are just some of the quotes that stood out to me when I was compiling my results. And yeah, I'll just read a couple of them out to you. So it frustrates me when doctors overlook the influence of our past. They attack me for not asking for help quick enough, but they need to understand that my hesitancy was not just about my medical history. I, like many other Black women, just don't trust the system. Too much has happened. When you see someone who looks like you think I belong here too, and that was in reference to materials and adverts in fertility clinics. When you go to the clinic and just see one type of couple on the posters, usually a white straight couple, it makes you think, do they actually understand us? Thank you for interviewing me. I feel like my story, our stories, are finally being heard, and I know I say this for a lot of us, that means a lot. It's not just about a baby that looks like me, even though that's what I want, but who wouldn't? It's about making sure that my child feels part of the family, even though biologically they may not be. And then people also spoke about the experience of actually being interviewed itself, which they did appreciate. So this was so empowering. Thank you. I feel like you see me. I forgot you were offering a voucher. Honestly, all I wanted was to be listened to. This is rare for me, but I feel like my voice matters. Next slide, please. So when I was going through and analysing my results, I did arrange it into 4 sections, and these were the main points that women spoke about. So when they were accessing fertility treatment, financial burdens. So people spoke about the financial strain of fertility treatment and how it made them feel, and the fact that sometimes they couldn't afford what they wanted to do. And they also spoke about how finance strongly influenced their treatment decisions. In terms of payment options, they spoke about concerns about overpayment plan accessibility, and they would appreciate more equitable options in that for fertility treatment. In terms of waiting times, women spoke about the added distress of waiting, and then people also spoke about, because I interviewed both private patients and NHS patients, and it was clear to see that the people who did access it privately were able to kind of reduce that burden on themselves. People also spoke about language barriers and complex terms hindering their interaction with healthcare professionals, and their need for culturally sensitive communication when they're accessing their care. And then people also spoke about the emotional impact of fertility treatment. So the range of emotions, like people described it as an emotional roller coaster, from hope, anxiety to frustration, and then joy if it was successful. So that just shows how intricate and emotional that the experience can be. People spoke about their need for support systems, so including any partners and peers, and also support systems from people who look like them and people who understand their journey. There was a focus on the lack of diversity in clinic materials, as people felt alienated and excluded from fertility treatment from the space. And people spoke about the fact that inclusive representation made them feel like they belonged, and it also made them feel like the care was catered to them. So I'll go on to just a couple more points. So people spoke about experiences where they felt that their race really did influence the quality of their care. So this highlights the need for like more awareness and training amongst healthcare providers. And then people also spoke about the fact that they want to be listened to. They want more platforms to be able to give their feedback and give their thoughts, and they want to feel empowered in their care as well. And they want to feel recognised and seen in the fertility space, and there is a need for them to have their voices heard. So yeah, next slide, please. So this, to conclude, I felt like I successfully shed light on the complexity of Black women's experiences and attitudes of fertility treatment by allowing them to tell their stories and allowing them to be seen, heard, and validated in the fertility space. And then one of the questions I did ask the women during the interviews was, what would you like to see in the fertility space regarding your care? And this has the potential to guide healthcare practices and policies through recommendations from the women themselves. And then the last slide, please. So these are the recommendations directly from the voices of the women. So they would like more tailored information and education, diverse representation and promotional materials, cultural competency and sensitivity training for healthcare professionals, supportive peer networks, something to address any like financial barriers, a holistic approach to their care, and more opportunities to give feedback to people undergoing their care. I think that was my last slide. Thank you.
Thank you so much, Okorite. And as a Black woman, I'd like to thank you for your research and all you've done to shed light on our experiences with IVF. And the hope is that more research can be funded and this can impact clinical practice and also policy. Thank you.
Thank you.
So next, but by no means least, we have Ruby. Ruby, please come in and introduce yourself and your work.
Hi everyone, I'll just share my screen. 1 second. Okay, can you all see that? Okay. Perfect, thank you. So yes, good evening everyone. My name is Ruby. I am a Senior Scientific Research Associate at Hertility. I am also the project lead of our Black Women's Health Initiative. And firstly, I'd just like to start by thanking Jenny and Fertility Network UK for inviting me to take part in this really important discussion. To give you a little bit of background to Hertility and what we do, Hertility is a reproductive healthcare provider that gives people access to a data-driven diagnostic test and telemedicine services, enabling them to get information about their reproductive health and fertility from the comfort of their own home. Today, I'm going to be speaking to you specifically about the research we conducted to look at the fertility inequalities experienced by Black women in the United Kingdom. So what do we already know about fertility inequality in the UK? Well, specifically for Black patients, this has been summarised previously, so I won't go over it again too much, but we do know that there is inequalities in terms of accessing fertility care, and there are several suggested barriers or theories behind why this may be happening. And there's also disparities in terms of success from fertility treatment and treatment outcomes. So we therefore wanted to look at data collected from women accessing our own services to see if this mirrored the delay in uptake seen with fertility treatment in the UK. And one of the important things to note here is that fertility as a kind of at-home hormone infertility test represents the first step in someone's fertility journey. So what did we do? Well, At Hertility, the first step in any fertility journey is we ask someone to complete an online health assessment. So as well as enabling us to collect important medical information to provide someone with an overall picture of their fertility potential, it also helps us understand a little bit about why someone has come to us. We looked at data obtained from over 200,000 women who approached us between September 2020 and June 2023. These women self-reported their age, they self-reported their ethnicity, whether they were actively trying to conceive, and the length of time they had spent actively trying to conceive before coming to fertility. From this, we looked at the average age of women approaching fertility, and then also used statistical tests to look and see whether there was an association of time spent trying to conceive between ethnic groups. So what did we find? Firstly, what you'll see is that of these over 200,000 women, approximately 25% stated they were actively trying to conceive when they came to fertility. The majority of these women self-identified as white, followed by Asian, then Black, then mixed, then other. And what was very reassuring to us was that we saw a very similar ethnic diversity to that of the UK population. So it really lends itself to the relatability and applicability of our results. When we were analysing the data, we found that we saw the most significant or greatest differences between both Black and white women approaching fertility. And so we delved a bit deeper into the characteristics of these two populations. If you could just look here at table 1, it shows the percentages of both Black and white women approaching fertility based on the length of time they had been trying to conceive before coming to us. So from 6 months or less, all the way up until 5 years or more. And what you may notice is that we actually saw a high percentages of white women approaching fertility earlier on in their fertility journeys, i.e. seeking answers or help with their fertility earlier, and less white women approaching fertility later on in their fertility journeys. However, we didn't see the same pattern with Black women, and what we actually saw was that Black women were likely to approach fertility later on in their fertility journeys and seek answers or help later on in their fertility journeys. Not only this, but if you could just look at table 2 down here, we actually looked at the average age of both Black and white women approaching fertility at each of these predefined time points. And what we see is that at every time point, Black women approaching fertility were on average older than white women. So this kind of ranged from about 1.4 years all the way up until 3.8, so roughly 4 years in women who'd been trying to conceive for 5 years. And this is a really important factor to consider, as we know that age is one of the #1 factors affecting fertility potential and fertility treatment success. And so all in all, this data suggests that Black women approach fertility testing services later on than white women. And as I said, this is important because this data is important because it's likely that fertility would be the first step in a lot of people's journeys. So off the back of this research, we decided to set up our Black Women's Health Initiative at Hertility. This group has been set up to use the resources available to us here at Hertility to collaborate with others who are already doing such amazing work to reduce the inequalities faced by people from marginalised groups within the UK. Our key aims as a group are to not only spotlight the crucial need for more diversity in research, both in the fields of fertility and healthcare more generally, but also to be able to amplify the experiences and stories of Black women in the UK and provide a safe space for them to voice these, as well as creating educational resources containing information that is up to date and evidence-based and designed with women in mind. So the initiative released its first report earlier this year, and it was focused on bringing together current published literature and fertility data to highlight what is known about the current state of reproductive healthcare for Black women in the UK. We wanted to create a resource that takes the onus off of Black women as educators, something to be used by everyone to help them better understand the barriers faced by Black women when it comes to their reproductive health. Our aim for this report was to not only highlight what is currently known, but also to use this to identify the gaps and next steps needed in terms of research, advocacy, education, and action. We worked with both scientists and clinicians to produce this piece of work alongside some amazing women who have given us the privilege of telling their stories and amplifying their voices. And I'd like to take a moment just to thank everyone who contributed to this report. At the time of writing, this report included data from over 8,000 Black women who self-identified as Black who approached fertility. And I'll now briefly share some of the findings from this work with you. So when we looked at symptoms reported, almost 80% of Black women who approached fertility reported at least one symptom. The most common symptom amongst these was actually fatigue. And we looked at some of the menstrual cycle characteristics, and what we found was that over a fifth of Black women reported having irregular periods, and over 1 in 10 reported having heavy periods. Next, we looked at the prevalence of reproductive health conditions in Black women, and almost 31% of Black women who approached fertility reported having one or more pre-existing reproductive health conditions before coming to fertility. And when we compared this to white women who approached fertility and the prevalences of conditions within this community, we saw that Black women were more than 6 times more likely to report a diagnosis of fibroids or uterine polyps. They were also more likely to report conditions such as PCOS or adenomyosis. And this is just a short snapshot of the data included in the report. There are many more insights that unfortunately we don't have the time to cover today, but I will include a QR code at the end for you to scan if you would like to read more. I would also like to say that our community is continuously growing, and so the most important thing for us is that this research needs to grow with our community. We plan to refine and update the report and continue to share these findings widely. And we really want to tackle the current information gap and really kind of translate scientific research as it happens and make it more and more accessible for women. Some of the changes that we've made as an organization already include collecting much more in-depth information on ethnicities, a recommendation coming from the charitable organization 5 Times More. We currently allow for people accessing fertility to select from over 90 different ethnicities, as well as an option to describe and self-identify on a deeper level. There is huge power in providing insights into the health and collecting information on the experiences of specific marginalized groups that have been underserved for too long. And we hope that this data can be used to improve the screening and management of reproductive health conditions. And so next steps for us as an organization and as an initiative is to really look at continuing this work surrounding the inequities in access to fertility treatment and care by surveying their attitudes and experiences. We also plan to address the knowledge and care gaps to produce short, free video content and educational resources, as well as looking at how we can make fertility services more accessible. So thank you for listening, and I'm really looking forward to the next section of the panel. If you'd like to find out more about fertility, you can follow any of the links here. And additionally, if you'd like to download the report, there is the QR code on the right-hand side. I'll just stop sharing.
Thank you so much, Ruby. It was really helpful to hear that detailed data analysis there. And yeah, I'd like to congratulate you on your report and initiative. And we look forward to hearing more about your work too.
Thank you.
So next, we'd like to share some reels from our social media campaign on why fertility equity is important. The campaign will raise the voices of people from the global majority affected by fertility issues and also feature professionals involved in addressing fertility and reproductive health inequalities. The campaign provides a platform for people from different cultures and backgrounds to share aspects of their experiences concerning fertility issues. So please like, comment and share using the hashtag fertility equity. And here is a few reels from the campaign.
My name is Avital. My name is Ephraim and I'm a trainee health psychologist currently in the 2nd year of my professional doctorate in health psychology at Glasgow Caledonian in order to qualify as a health psychologist in 2025. My research currently consists of infertility amongst diverse communities, in specific Black, Asian and minority ethnic women. Across all fields of healthcare, racial and ethnic minority groups are more likely to face discrimination, language barriers and institutional mistrust. As such, social factors and patients' experiences with healthcare services may also contribute to health inequalities and poorer service quality outcomes. Research also suggests that women from diverse communities, and in particular women from Black, Asian and minority ethnic groups, encounter additional challenges or disparities in gaining access to appropriate fertility care. Moreover, there is an increasing demand from women identifying from such backgrounds, specifically regarding health inequalities which occur because they feel that their voices need to be heard. They feel that there needs to be an increase in the way that the healthcare system responds to them. For example, there could be women that have English as an additional language, and therefore they need that support to feel heard and to feel understood by medical practitioners and practitioner psychologists to ensure that their opportunities for treatment is fair and equal opportunities as per women who identify from other groups. As a result, I feel that fertility equity is important.
I'm Raif Faris, a consultant gynaecologist at the Lister Fertility Clinic in Chelsea. Fertility equity is one of the disparities that persist within our healthcare system, which is a disheartening truth, and this is due to combination of socio-economic factors, systemic bias, and inadequate representation. Individuals from these backgrounds often face a steep uphill battle when seeking fertility care, making the dream of parenthood seem unattainable for many. Equity in fertility treatment is not just a matter of healthcare, it's a matter of justice, compassion. It is about acknowledging and addressing the unique challenges that individuals from different cultural and ethnic backgrounds face when trying to build their families. These communities often grapple with deeply rooted tradition, norms and stigma that can impact their access to care and support. The lack of equity makes these individuals feel they are left behind in their pursuit of a fundamental human experience. Achieving equity means breaking down these barriers, ensuring that everyone, regardless of their cultural or ethnic background, has equal access to affordable, sensitive and inclusive fertility care. It is a call for action for all of us to confront these disparities head-on, advocating for comprehensive, inclusive accessibility to fertility treatment for everyone. It is time we cultivate a future where equity in fertility treatment is the norm, not exception.
Okay, thank you for that. We've now come to the point where we are opening up to some questions and answers that you can put forward to the panel. So please do type in the chat or in the Q&A box. And I can kick off with a question that's come in, and anyone can feel free, anyone on the panel, if you feel moved to answer this, please do. So the question that's come in is, what do you think are practitioners' responsibilities in addressing the disparities and inequalities in fertility healthcare?
I'm happy to jump in just quickly. I think practitioners have a responsibility to be cognizant of the inequalities experienced by people from specific marginalized groups, so be knowledgeable about what patients may be facing throughout their treatment journeys. So not just when they come in to present to you with their questions, but what other external factors as well may be affecting them differently from perhaps patients from other different groups. And also to understand and be culturally competent and foster an environment of co-creation with your patient. So really working together and collaborating and listening and understanding. And I think that we are definitely seeing that there is more of a push for healthcare practitioners to foster that kind of, to develop cultural competency and foster that, I guess, environment of co-creation with their patients. But it's also about recognizing and giving and having the capacity to provide that culturally competent care within a healthcare setting as well.
Thank you, Ruby.
Can I add something to that, if I
Please
may?
do. Yeah.
Because I think Ruby makes a very important point. I've over the years worked with some incredible healthcare providers and practitioners who have been happy to meet with groups like mine and many others to understand the religious and cultural sensitivities of the patients that they are going to be caring for. And it often doesn't take an enormous amount of effort to understand the background and the priorities of some of the patients that you're caring for, but the benefits so far outweigh the efforts, and the ability to create a warmer, a more understanding, a more empathetic rapport with the patients, or the patient's spouses or their families or whoever it is that is supporting them. Unfortunately, it does take an effort. There's no question of a doubt. But I think that the benefits, certainly that I've seen with the different practitioners that I've worked with over the years, far outstrips any effort. And I think that often, you know, if you go back and talk to them, you know, when you do the debriefing and those sorts of things, they do often say that they were able to have a much more positive rapport and reach a much better outcome with their patients by working with them from a position of knowledge and understanding. And so I think that it's got to be the way forward.
Both. And we've got another question come in. So as the healthcare system continues to grapple with operational and strategic issues during challenging times, with competing pressures on integrated care system budgets, how can we ensure the voices and needs of racially minoritized people are central to the decision-making process?
I think for that question, I think one of the things to do is to really make sure that people feel like they can be heard. So opening up spaces where people are able to give their feedback and people are able to talk about their care, and creating safe spaces for people to be able to go to tell their stories. I think that would really help.
Thank you, Okorite.
Sorry, I think there's some fireworks going off in the background, but I hope you can still hear me. Yeah, I was just going to follow on from that. And I think that it's very important that when we are making these changes and we are implementing, we're learning from past mistakes. And some of those past mistakes have been not including people from lots of different backgrounds in service design, provision and delivery and evaluation processes. And so as we are making changes in the healthcare system and being forced to adapt, a really important part of that is learning from past mistakes and really fostering kind of, involving people in discussions earlier, so we can ensure that we have suitable and, services that are fit for purpose.
Great, thank you for that, Ruby. And another question that we have is the London Mayor's Health Inequality Strategy Implementation Plan 2021 to 2024 explicitly highlights the importance of tackling systemic racism as a root cause of ill health. How can the fertility healthcare sector address racism and the role it plays in entrenching inequalities?
I think some of that really, and it's always helpful to be reminded of where some of this conversation comes from. I think that one cannot underestimate the need and the essential role that education has in this conversation. It is often difficult to understand people's differences if you do not know where they're coming from, what their value systems are, what their priorities are. It is wrong to assume that everybody lives by the same priorities and the same value systems. And I think that by being able to explain, to educate, to share, it can really have a huge impact on the understanding. At the end of the day, I really do believe that people go into the healthcare professions because they care. That emphasis on the word care, they are not doing this for their own gains. They work incredibly hard. They work in increasingly difficult conditions, and you know, I think it's become a struggle as much for the people working in the profession as it has for the people trying to access the profession. I often hear from healthcare providers how frustrated they feel that they're not always being able to deliver what they would like to deliver. But I think if there is more education and knowledge and understanding of where the minority groups are coming from and what their values and priorities are, I really do believe that that will be helpful.
Thank you. An additional question we have here, just following on from that, is should bodies such as NICE recognise racial injustice in their guidelines?
I think the only way to kind of make a change is to recognize when things are going wrong, or things that have gone wrong. Like Ruby said, it's all about learning from past mistakes or past judgments. And I think without recognizing the injustices, I think that's what injustice, without recognizing that, they won't be able to actively act on it to make a change, really.
Yeah, and I think it all goes back to that education piece. If we're not openly talking about injustices or inequalities within our healthcare system, and they're not openly available for everyone to read and view, then, you know, we're not acknowledging the problem. And yeah, just to echo that, I think it's really important.
Thank you. So our next question is looking at some of the socio-economic factors that affect our communities. And the question is, if we know that some minorities are less likely to be successful with IVF, should there be different criteria in terms of access to NHS funding, i.e. earlier recourse to IVF?
Very difficult question to answer, because unfortunately we know how broken the system is. And I think the difference between what we would love to see happening versus what we know in real time is happening actually makes it really hard to answer a question like that, unfortunately.
Thank you. I'm delighted to have Dr. Venki back, who's actually on call at the moment. So thank you for coming back, Dr. Venki. And we totally appreciate you being here. And if you have to disappear,
no problem. Thank you.
Do your work. So we're just at the question and answer point in the webinar. Another one that's come through is, how can national and local policies be changed to become more inclusive of women from Black, Asian and minority ethnic backgrounds?
Sorry, was that for me?
Feel free to answer that, please do.
No problem. Yeah, I mean, I think, you know, it's very important. You're absolutely, it's a really, really good, important question. I think at every single level, we need to be driving and hammering this on a daily basis. So, I mean, a lot of the things that we do in fertility, you know, we find that, you know, we get a momentum, then things stop, and then we don't hear about it. And a couple of months later, somebody may raise it. I think the key thing that we need to be doing is we need to be drumming this every day, getting through the legislative work that shows that there is a disparity and that we need to take action on this. And I think my personal view is we as fertility providers have a key role in that. And I think the HFEA, along working with the regulators, should really take action on this. And that's something I'm personally very keen to try and pursue.
Sorry, I was just trying to unmute myself. Thank you very much for that answer. And just following on from that, there's a question here. Research shows how the late diagnosis and treatment of gynae comorbidities, particularly in Black women, leads to worse fertility outcomes. What needs to change in policy to address these disparities?
I mean, I think, again, yes, I very much think about working at the hospital that I do and treating the community and the various ethnicities that we do treat on a daily basis. It's clear that there are different needs. It's understanding those different needs and working to, create clear pathways in place that, that we are targeting and addressing the health needs of our community, of ethnic minority communities. So a simple example of that, for example, is given where we work and the demographics, there's a high population of fibroids within the population that affects fertility as well as general gynecological health. We have worked with in terms of trying to make sure that we address that the streamlined pathways. We understand as a care group what is the service and delivery needs that we need to be providing to these patients, and we should be working, with the CCG, with legislative groups to understand that there is specific health needs for the group, and we do need to take action and address these.
Yeah, I completely agree. And also just to follow on from that, I think there's also a responsibility of policymakers and, organizations to really kind of look to work with support groups, work with patient groups, and work with, kind of community leaders to make sure that the education that they are putting out there is getting to women and getting to the people who need it. And I think, I think it's just the communication and the making sure that the education is disseminated to those who need it most.
Thank you. So I'm conscious of time. We've got probably just some time to take a few more questions. Next one that's come in is, how can the gaps in research and funding and the lack of health-based data be addressed within our communities?
I think that funding for research, unfortunately, is something that's often scarce. And I think the thing that's much more difficult is that couples want to have treatments and they want to see results, and they don't necessarily prioritize the research, quite understandably. And therefore, I think that the clinicians and the clinics really need to take a little bit more responsibility in trying to collect data and encourage couples to be part of research, and to help them with the understanding that it's not going to impact on their treatment if they do take part in the research. Very often people are very concerned, especially if they're paying for the treatments themselves, that by being part of a research study, it's going to have a negative impact or possibly have a negative impact on their treatment. And they just can't take that risk. They haven't got the time, the money, and more importantly, the overwhelming desire to have the child is the primary concern in their minds. And so again, I think the communication would really be helpful with that.
Thank you. I was just checking if any of our researchers wanted to come in there, but it's fine if you don't. Okay. And so did you want to come in, Ruby?
No, yes, just to agree with Dr. Veronique. I think it's, funding is scarce, but I also think it's also about encouraging and inspiring young researchers from communities and from ethnic minority communities to really work with organizations and undertake this research. And I think that there is a real need for change, and I think a lot of young people and young researchers are feeling this. So when there's funding and I think people are given the opportunities, definitely the research will be done. And I think the more and more conversations are had, the more there is pressure to create those pots of funding for research to generate change. So totally, as well as reassuring patients and bringing patients on that journey with you and making sure that they feel confident and comfortable in the research, but also that funding piece as well.
Great, thank you so much. Someone's asked, as Black women look for fertility help at later stages, what do you think could be done to change this trend?
I mean, my personal views, I think the key is education here. And I think the key is to get this message out. I mean, we know that fertility treatment is very closely linked to age. We know the outcomes are worse. The key is that we need to be engaging with the community. We need to be engaging with key stakeholders who liaise with our community on a daily basis. Get it out there about what are the facts of infertility, dispel any myths and misinformation, and make it clear to our population and our community that, you know, treatment is there and it is accessible, and direct them as to how to be able to access this opportunity.
Most definitely. I'll just move on to the next question then, before the last question. So as we know, the work can be very tiring, and particularly when you come from within the communities that are disadvantaged and facing the disparities. So we need sustainable action to affect change in fertility access services and outcomes. How can change makers be appropriately supported to deliver this change?
I think to answer that question, it's about making sure that the people who are actively pursuing the change have the safe space to also relay any thoughts or experiences they're having about what they're doing, and making sure that people feel heard. Like you said, the people who are actively doing the change, they do need to have that safe space to be able to go to kind of debrief everything they've listened to and everything they've heard. So yeah, I think that would be useful.
Yeah. And so we've come to the point where we're going to ask each panel member to state a call to action. Accountability and commitment to action is needed. So if you could say briefly, what is your call to action to policy and decision makers in the fertility field? Feel free to jump in.
Okay, someone has to go first. I think the call to action that I would really love to see, and I really think actually would probably resonate with lots of groups, not just the Jewish community, is the possibility to have educational programs rolled out in a sensitive environment, being able to go into faith schools, to be able to talk to faith leaders and teachers in a way that is comfortable for them to hear, but the messages are very, very clear. They need to be teaching young people about their fertility. They need to be teaching young people about the need to, whether it's freeze eggs, whether it's have the conversations, that there are safe spaces to talk to people about intimacy issues. There are safe spaces to access treatment, that they don't have to suffer and don't have to feel left out. Because knowledge is power when it comes to accessing services. And so I really think that the bottom line is educating young people.
Thank you, Veronique.
If I could add just that in trying to lead this creative writing workshop about fertility, a lot of people came up with shame around the subject, which I think prohibits a lot of people from talking about it. It's not like any other physical problem. It seems to have a very strong dimension of feeling ashamed and feeling like a failure. So yeah, the work we were trying to do and still doing is to try and just talk about personal experiences very, very openly, and not and maybe by example give that opportunity for people to open up and feel that they're not alone and they don't need to suffer in isolation and feel ashamed that they can't do what everyone else can do. Yeah, I guess call to action is just to have a lot more of those spaces. In my way to deal with it is creatively, but yeah, just and especially in traditional communities, when often I've found not just the Jewish community, I reached out to a lot of Muslim communities in Sheffield, where I live, trying to make this workshop happen. And I found that a lot of women are think it's their fault that they can't conceive, and therefore, or if they did have a problem and then they did manage to have a child, then they don't want to talk about it. They don't want to open it up at all. So there's definitely that element I seem to come across, that women feel like they're to blame and therefore don't want to speak about it openly.
Thank you, Avital. So anyone else? We've just got a few more minutes. We've gone slightly over, but we will be ending shortly. So does anyone else have a call to action that they can share?
For me, so I mean, I have to keep it a bit short because I have to leave in a second. But for me, it's really important. I think I've said this throughout this webinar, that I really would call to action. I really want the HFEA and I want the fertility providers really to make this a priority and to really engage on this. That making our care for ethnic minorities and for the ethnic minority communities, allow them to access care easier, improve their outcomes. Because what we're looking at fertility is just a snapshot. We're talking about the health of men and women for many years to come. And this is one opportunity to treat that. We know that in pregnancy, we know that in later life, that again, ethnic minorities have disparities in their health outcomes. Fertility is a key opportunity to address those differences in healthcare needs. And I really think that if we can address it at an early stage and treating these men and women with more equitable care, then we will have better outcomes for our community.
Thank you very much for that. Thank you.
I had one. My call to action was there just to be more ongoing research to capture what people are feeling and their challenges and decisions, especially from Black and ethnic minority people who are seeking fertility treatment. I think we really need to listen to the people who are actively undergoing the treatment and embrace their thoughts and recommendations to make sure that this fertility space and their treatment is more inclusive and more compassionate.
Thank you, Okorite.
Yeah, and just to completely echo that, I think that like I said, it's all about making sure that our services are fit for purpose and that they're culturally sensitive and that they hold the patients, no matter what their background is, at the heart of that. And it's really listening to patients from all different backgrounds, but particularly ethnic minority patients who haven't been heard for a very long time.
Thank you very much for everybody. Thanks, Ruby. Thanks, Veronique. Thanks, Okorite. Thanks, Avital. And Venki, I think he's gone, but thank you, Venki. I hope that this webinar acts as a gateway, not only for further conversations on these issues, but also for further exploration and action towards fertility equity. So a big thank you to our wonderful speakers for being with us tonight to answer our questions and to share their valuable insights. Thank you all of you who joined us too, and for bearing with us for the technical issues. Please don't forget, we are your charity and we are here for you. If you need support, we have groups across the country and some UK-wide groups, including a Black women's group, a South Asian group, and a Muslim women's group. And you can contact me, the Fertility Network UK Ethnic Minorities Community Project Worker. And we also have a support line and information line open every weekday, sorry. So don't hesitate to get in touch if we can help you. So that brings our webinar to a close now. Once again, want to thank you all for being here and hope to see you again soon.